Okay, so in this module, we're going to talk about minerals, vitamins, and towards the end, we're going to talk about TPN, which is total parenteral nutrition, which is intravenous nutrition when the gastrointestinal tract is not able to absorb nutrients for a number of reasons that we'll get into. Okay. Okay, not going to spend too much time on this slide, so you can jump to the next one. Okay, so let's get into the benefits of vitamins. And remember, a vitamin is usually a nutrient or a chemical that needs to be absorbed by the body. It is unable to make this molecule, but the molecule is involved in many processes. So it's essential that that vitamins are absorbed into the body or activated within the body. Okay, since they run so many processes. All right, and the first division I would think of is fat soluble versus water soluble. Fat soluble vitamins are easily stored in the body, in particular in the liver. So that would be vitamin A, vitamin D, vitamin E, and vitamin K. So water-soluble vitamins, which are the B's and the C's, don't tend to get absorbed in the body. So if you consume large amounts of vitamin C, for example, you'll notice that your urine will change color. It'll kind of turn this orangey color. And that's just vitamin C being excreted because the body does not store water-soluble vitamins. Okay, so let's look at the first one. This will be a longer slide, but it'll make the other slides easier. So vitamin A, which is retinol or beta-carotene. So this vitamin is essential for visual development. Okay, it's involved in development of the retina. So vitamin A deficiency in an infant, which would be very rare, would cause visual issues. It's involved in the immune system. So again, reduced immunity with vitamin A deficiency, and definitely involved in soft tissue and skin development. So that's why you'll see a lot of vitamin A creams for acne, for anti-aging. There's all kinds of expensive vitamin A creams. So just remember those areas of the body: vision, immune system, soft tissue, and skin development. Okay. Now with vitamin A, you'll more likely see someone who's ingested too much vitamin A compared to having too little. Someone who, for example, who's consumed large amounts of carrots will turn orange. It's completely safe. It's not, the color will go away when they reduce the consumption of, say, carrots. But it's a very obvious skin color for someone who's ingested large amounts of vitamin A. So that's called carotenemia. Okay, so high vitamin A levels in the bloodstream. So where can you get large amounts of vitamin A? So you can get it definitely with meats, for definitely the liver. So the liver is packed with fat-soluble vitamins. Okay, so you'll get a lot of nutrients from eating, if you like eating liver, and fat-soluble vitamins is definitely one of them. Okay, vitamin A toxicity is very uncommon. So it's more than just turning orange, say with carrots. It's being toxic on vitamin A. And that's where you can have nausea, weakness, altered mental status, blurry vision, hair loss. That would be extremely unusual. The only time I can recall having heard about this was many years ago. There was a ship stranded up north in the ice, and this is a few hundred years ago, and the crew were starving. So they ate tremendous amounts of seal and polar bear liver, and some of them died from being toxic with vitamin A. Okay, so just remember the high sources of vitamin A: liver, sweet potatoes, carrots, broccoli, pumpkin, melon, all have large amounts of vitamin A. And also remember that the fat-soluble vitamins can last a long time even if you don't ingest them, because you have such vitamin stores in the liver. Okay, unlike the water-soluble vitamins that really aren't stored. Okay, vitamin B9, so that's folate, so folic acid, and that's definitely always added to maternal vitamins, right? So in actual fact, it's better to take folic acid before becoming pregnant, because often in the first couple of weeks you don't know you're pregnant, and the neural tube, neurological development starts around week 3. So it's better to have folic acid on board when there's fetal development. Okay, early first trimester fetal development. Now, a lot of the B vitamins aren't listed here, like vitamin B1, which is thiamine, B12, which is riboflavin. B1 is thiamine, B2 is riboflavin, not B12. B3 is niacin, B5 is pantothenic acid, and so on. So a lot of those vitamins are heavily involved in metabolism, cellular metabolism, and it's almost impossible to be deficient in those vitamins because they're in fortified cereals. They're added to so many things, right? So really the only time you can become, say, B1 deficient, which is thiamine, or riboflavin, which is B2, or niacin, alcoholics. So alcoholics tend to wash out their water-soluble vitamins very quickly because their diet is often alcohol-based and they're not getting a lot of other nutrients. Okay, so that's why when alcoholics are admitted into hospital, they're often put on IV vitamins to replenish a lot of the vitamins that have been missing in their diet. Okay, so B vitamins in general, whether they're in meat, enriched flour, for example, beans, whole grains, molasses, again, cereals are enriched with B vitamins. So pretty easy to maintain your B vitamins. Okay, we're going to come back and talk about, actually let's just talk about B12 here for a minute. Okay, so B12, vitamin B12 is one of the 8 vitamin B vitamins, and it's heavily involved in the nervous system and maintenance of the myelin sheath, and also in maturing and developing red blood cells. Okay, so you require vitamin B12 and also actually folate for red blood cell maturation and production. Vitamin B12 is important for myelin sheath maintenance. Okay, so that's the nervous system. And the folate, so B12 has an extra on top of red blood cells. It's the myelin sheath and RBC production. Folate, RBC production, and prevention of neural tube defects. Okay, so B12, when you eat it or ingest it, it requires a protein that's secreted by the stomach called intrinsic factor. Okay, and think of intrinsic factor as the chauffeur for vitamin B12 through the gastrointestinal tract, because most of vitamin B12 is absorbed in the distal small intestine called the ileum. So B12 combines with intrinsic factor and migrates through the duodenum, the jejunum, and is absorbed in the distal ileum, okay, into the systemic circulation. So if you have an issue if you have a disease that causes a deficiency of intrinsic factor, then you will have a very difficult time absorbing vitamin B12 because it can't be chauffeured to the distal ileum as easily. Okay? So that condition is called pernicious anemia. So you become anemic because you're not absorbing B12 based on the fact that you're not producing intrinsic factor. And why aren't you producing intrinsic factor? Well, for a number of reasons. You may have had gastric surgery, so part of your stomach is missing. With the aging process, and just with certain conditions of the stomach, where you get chronic gastritis, so chronic inflammation of the stomach, many people can get, whether with alcohol or just the aging process. You get what's called atrophic gastritis, meaning just a general, so atrophy means wearing thin. So atrophic gastritis means that the stomach has an inflamed lining that's just not functioning as well, so it's not producing intrinsic factor. So you don't absorb vitamin B12 as well, and you develop pernicious anemia. And you can also develop some neurological symptoms, because remember, B12 is involved in maintaining the myelin sheath. Okay, so let's look at the other side of the coin with vitamin B12. If you have a disease at the distal ileum, you may not be able to absorb vitamin B12. And a very common disease that affects the distal ileum is Crohn's disease. So you can be B12 deficient. And it wouldn't be called pernicious anemia because that is lack of intrinsic factor only that causes the B12 deficiency. You would just be vitamin B12 deficient from Crohn's disease. Okay? So just remember, with vitamin B12, what does it hit? It causes anemia, and it causes poorly developed red blood cells. So they're large. So it's called megaloblastic anemia. They're large red blood cells. They haven't matured very well. So it causes a megaloblastic anemia. And also some neurological changes due to lack of maintenance of the myelin sheath. So tingling in your feet. Poor balance can be from vitamin B12. All right, let's go on to vitamin C. So vitamin C, also called ascorbic acid, so a water-soluble vitamin, definitely involved in maintenance and repair of soft tissue. For example, if you've had some kind of skin wound, it maintains the gums in your mouth. So For example, if you're extremely vitamin C deficient, you'll have very poor wound healing. You'll have poor dentition. Your teeth will be weak. They'll be weakly held in your gums, because the soft tissue is very reliant on vitamin C. Possibly more prone to the common cold. There's not absolute proof there, but it is felt that low vitamin C levels can predispose you to the common cold. Since vitamin C is also involved in the immune system. It's also considered an antioxidant. So antioxidants are involved in preventing cancers. Oxidation of the body and of cells is bad. So antioxidants such as vitamin C can prevent cancers. Scurvy is the condition where you are deficient of vitamin C. But this would be a very rare disease now, because vitamin C is in so many foods that we eat. And this would be a disease of many years ago. The ships that came over from England to North America, where they didn't stock fruits and vegetables. So they didn't have fruits or vegetables for months. And they began to get skin sores, bleeding gums, very poor wound healing, bruising all over the body, infections because of reduced immune system. This was related to vitamin C deficiency, called scurvy. So sources of vitamin C, very easily obtained in modern day: fruits and vegetables. So strawberries, oranges, lemons, grapefruit, mangoes, tomatoes, blueberries. Very high in fruits and vegetables, not so high in meats. Okay, on to vitamin D, fat-soluble vitamin. So vitamin D is actually made in the skin with sunlight. And really all you need is 20 to 30 minutes of sunlight per day, which will provide enough vitamin D production for the day. So it's really northern countries where people are dressed up in jackets for half of the year or longer, where a lot of the population is vitamin D deficient. So we'll get into more about vitamin D metabolism a bit later. But vitamin D is heavily responsible for helping calcium be absorbed from the intestines. Okay, and where can you find vitamin D in foods? Not that many. You're actually producing it in your skin. Well, the inactive form, anyways. There are some food groups. The very oily fish, such as salmon, can and do provide some vitamin D, but often people in northern climates that don't have a lot of sun exposure need to take vitamin D through the winter months to maintain normal vitamin D levels. So the inactive form that's made in your skin is converted to an active form through a process that I think we'll get into a bit later, but it's initially converted in the liver, and then it's finally converted in the kidney to active vitamin D, which will then absorb calcium in the gastrointestinal tract. So if you're vitamin D deficient, well, it depends if you're an adult or a child, but if you're vitamin D deficient as a child, and you're not absorbing calcium, which is critical for bone development, then you can potentially develop rickets. If you're vitamin D deficient as an adult, say you moved to a northern climate, you you didn't realize that you needed to consume or take vitamin D supplements through the winter months, you became vitamin D deficient. Well, you develop a condition called osteomalacia. It's similar to rickets, which is a child. It's soft bones. Okay, so the matrix of the bones is softening in osteomalacia. Rickets is the fact that you didn't lay down proper calcium levels into the bone matrix because it wasn't being absorbed by the vitamin D. Okay. Modern day diets, a lot of things are fortified. So, for example, milk, dairy products, and meats in America, they have vitamin D in them. Now, remember, with rickets and osteomalacia, you have fragile bones. Your leg bones, because that's what you stand on, they're so soft that they can bend, so they bow out. Frequent fractures can occur. Okay, so remember, vitamin C made in the skin in the inactive form, fully activated as it goes from the liver to the kidney. How can you get vitamin D in your diet? Oily fish such as salmon, tuna, sardines. Of course, liver itself will be filled with vitamin D because that's where the fat-soluble vitamins are stored, and egg yolks. Okay. All right, on to vitamin E. So vitamin E is considered an antioxidant vitamin. We think that it has protective effects to cells from producing mutations, which can then lead to cancers. Okay, I mean, there have been many studies with vitamin E, so we haven't definitively proved that. But as an antioxidant vitamin, we think that it has beneficial effects in that way. It also can have some blood thinning effects, especially when combined with medications that are blood thinners, like anticoagulants, warfarin, clopidogrel, or even just aspirin. So vitamin E combined with blood thinners can be a bit of a no-no because it can aggravate the blood thinning effect. How do you find vitamin E in your diet? So typically nuts, so almonds, sunflowers, hazelnuts, peanuts. Fish can have vitamin E, and eggs. Okay, and let's go on to the last one. I know this has been a long slide. Vitamin K. So vitamin K, also fat-soluble vitamin. Definitely an important vitamin. It is needed to produce coagulation factors for clotting. Okay, so if you are vitamin K deficient, then you run the risk of having poor clotting ability and increased bleeding risk, such as bruising, bleeding, or even hemorrhages. Okay, again, hard to be vitamin K deficient because you store these fat-soluble vitamins for many, many months. And vitamin K is usually in your leafy vegetables, right? So kale, spinach, broccoli, Brussels sprouts, cabbage will be high in vitamin K. Okay, and vitamin K we use as a drug to reverse the effects of a very elevated INR when someone is taking warfarin, right? So warfarin inhibits vitamin K dependent coagulation factors from being produced. So how can we reverse that? We can give the person vitamin K, which will allow the factors to be produced if we think that the INR is too high. It's causing too much of a thinning effect on the blood. And vitamin K can be given IV, it can be given orally, it can be given as a subcutaneous shot. Newborns, before leaving the hospital, get a shot of vitamin K, since they can be a bit deficient. And it's just to prevent bleeding in the newborn, so they get a shot of vitamin K before leaving the hospital. The other vitamin I just want to mention again is vitamin B12. So yes, it's a B vitamin, but it is also stored in the liver. Okay, so you have many, many months, over 6 months, and in many cases over a year of vitamin B12 stores in your liver. So you can imagine that to become B12 deficient, there's definitely something happening either with intrinsic factor in the stomach or absorption in the distal ileum. So we'll get into that a bit more later. Okay, so these vitamins should go much faster now since we spent 25 minutes on the slide above. Vitamin A deficiency, very rare now. When do you need increased amounts of vitamin A in your diet? That would be pregnancy and lactation, right? Since there's higher requirements for it. But a deficiency would be almost unheard of now. Where is vitamin A required? In the eye and epithelial cell development. So skin development, mucosal development, such as in your mouth, into your lungs, that's all mucosal, and tissue development. So that's important for vitamin A. Below is showing you the food sources that have vitamin A: liver, egg, milk, butter, and some vegetables. And remember, with the fat-soluble vitamins, so you need proper functioning of bile. Okay. So if there's an issue with bile production from the liver, such as a blocked bile duct, or say severe hepatitis, you can have malabsorption of fats and fat-soluble vitamins because you're not producing as much bile. What about in a condition such as pancreatitis? Well, pancreatitis, you have lipases. You secrete proteases to break down proteins. You secrete lipases to break down fats. And you secrete enzymes to break down sugars as well, right? So if you have pancreatitis and you're not absorbing fats because you're not secreting lipase, then not only are you not going to absorb your fats or break down your fats, but you're not going to absorb your fat-soluble vitamins as well. Okay, so malabsorption syndromes will definitely impact fat-soluble vitamins. What about a condition such as Crohn's disease, where you have inflammation of the small intestine? You typically reabsorb a lot of your bile at the distal, in the ileum. Well, if you have Crohn's disease, and the ileum is a very common place to have Crohn's disease, the distal part of the small intestine, you won't absorb your bile, and you won't absorb your your fat-soluble vitamins as well. Okay, so any malabsorption condition of the small intestine will make it difficult to absorb your fats and your fat-soluble vitamins. Okay, so vitamin D. So vitamin D is responsible. It's a fat soluble vitamin, and it's responsible for absorbing calcium, magnesium, and phosphate in the small intestine. As mentioned before, very difficult to get vitamin D in food products, enough vitamin D in your diet. So it's made in the skin in an inactive form called cholecalciferol. You can get it in some oily fishes, and in cow's milk it's been added now. As well, many breakfast cereals have vitamin D added. So it's a bit more difficult to become vitamin D deficient, but definitely in northern countries where people are dressed in winter jackets for 6 months of the year, vitamin D deficiency is an issue. So as mentioned, you can form the inactive vitamin D in the skin. It is activated in two steps. The first one is in the liver, and the second one is in the kidney. The active vitamin D is called calcitriol. Calcitriol. That's the active vitamin D that can now absorb calcium, magnesium, and phosphate in the small intestine. Now, technically, because you can produce this vitamin in your skin, it's considered more of a hormone than it is a vitamin, even though we call it vitamin D. And because vitamins are really considered essential in your diet, whereas vitamin D is produced in your skin. Okay, so cholecalciferol, made in the skin, converted to calcifidiol, calcifidiol in the liver, and finally converted to calcitriol in the kidney. And that is the active vitamin D. And this is the vitamin or the hormone that's responsible for calcium homeostasis and metabolism, right? Since it can absorb calcium and phosphate in the small intestine. So without proper levels is where you run into rickets in childhood or osteomalacia as an adult. So really vitamin D is heavily involved in bone health, right? So deficiency in children will cause rickets. Deficiency in adults will either cause osteomalacia, which is softening of the bones, or it can lead to osteoporosis, right? So especially post-menopausal women that no longer have estrogen, they lose their calcium from their bones very quickly. So vitamin D and calcium replacements become very important for postmenopausal women. Okay, so here's vitamin E. We already mentioned that it has antioxidant effects, so it's protective to cellular damage. And also it has some blood thinning effects, so protects against blood clot formation, although can aggravate bleeding if given with an anticoagulant medication. Okay, so remember that if you see vitamin E and someone's on an anticoagulant, probably not a great combination. Okay. And below we've already listed the food sources that you find vitamin E. Okay, vitamin K. So vitamin K, again, responsible for synthesis of some of the clotting factors in the liver. Not all of them, but some of them. So low vitamin K levels can result in poor clotting and increased bleeding. We also, so in someone, that's one important thing to remember in terms of vitamin K and its deficiency, that it can lead to bleeding. So warfarin, which is an anticoagulant, we use it for DVTs, pulmonary emboli. We use it for atrial fibrillation. We use it for people with prosthetic heart valves. Sometimes the INR can just get too high, right? We usually like INRs between 2 to 3 for most conditions. 3 to 4 for a mechanical heart valve is preferred. For many reasons, the warfarin can cause very elevated levels of INR. 7, 8, 9, 10 sometimes when we check it. And if the person's not actively bleeding, but they have an INR of say 9 or 10, we'll bring it down by providing them with vitamin K supplement, right? And we can give this orally or IV or subcutaneous. And within a day, it brings the INR back down. And then we'll usually try and find out why their INR became so dangerously high. It may have been they were put on an antibiotic. It may have been a medication change or a dose change of the warfarin, or it could have been a change in their diet. Maybe they went traveling and their diet completely changed. Okay. And then all newborns are given a dose of vitamin K before leaving hospital. And I think that's it. In terms of food sources, you see them there. Definitely the leafy vegetables, spinach, Brussels sprouts, cabbage would be high in vitamin K. Liver, for sure, all fat-soluble vitamins. Okay, so vitamin B1. So remember, we have 8 B vitamins. Most of them are heavily involved in enzyme reactions, metabolic reactions in the body. Okay, some aren't, but most of them are. So, such as thiamine, niacin, riboflavin that we'll come to. So when do they get to? So these are water soluble, right? So if your diet is poor, you're going to become vitamin B deficient. And an alcoholic is the classic patient that will become thiamine deficient. Okay, they're added to prenatal vitamins to make sure that pregnant women are getting proper amounts of B vitamins. And older patients that really have a poor nutrition, they have difficulty getting out to the store. They don't eat a lot of fruits and vegetables or fortified cereals. They can run into problems with B1 deficiency. So as mentioned, it's a coenzyme in many metabolic reactions in the body to metabolize the sugars, the proteins, and the lipids. And when alcoholics come into the hospital, we often give them thiamine injections or IV thiamine to replenish their thiamine levels. Okay, the food sources are listed below there. So what happens if an alcoholic, for example, becomes deficient in thiamine for a long time? So you can get this condition called Wernicke's encephalopathy or Korsakoff syndrome, and it's a spectrum but they get neurological symptoms. So Wernicke's Wernicke's disease and Korsakoff syndrome. So visual changes, off balance, so ataxia, memory loss, confusion. And this can definitely happen with thiamine deficiency in alcoholics. So almost always they're given thiamine or vitamin B replacements. Okay, I'm not going to spend too much time on riboflavin. Again, it's a cofactor in metabolism. It's a water-soluble vitamin. Who's going to run into trouble? Alcoholics. So vegetarians can run into trouble with riboflavin, and vegans, people that don't drink milk at all, definitely need higher levels of pretty well every vitamin with pregnancy and lactation. A lot of things are fortified with the B vitamins, just like B1. B2 is in enriched grains, fortified cereals that you buy. It's also in milk and eggs. So hard to become deficient unless you're not eating properly, such as an alcoholic. Okay, and if you're not really following a varied diet as a vegetarian or a vegan. Okay, vitamin B3. Again, the action. What's the main action? Why do you need small amounts of B3 in your body? For metabolism, just like thiamine and riboflavin. So nothing too earth-shattering there. Why do we use it as a drug? So we use it as a drug. So niacin is B3. One of the indications is high triglyceride levels, and you'll probably remember this from your talks on hypercholesterolemia and drugs to treat high cholesterol. But with patients with high triglyceride levels that are either developing pancreatitis or at high risk for pancreatitis, we'll bring down the triglyceride levels with niacin. Okay, high doses of niacin. So pancreatitis with elevated triglyceride levels, or just very high levels of triglycerides themselves, we can use niacin to bring it down. The main side effect of niacin, if you recall, is flushing. How can we prevent the flushing? By giving aspirin about half an hour prior to the dosing of niacin. Okay, and here are the sources below that has niacin contained in them. Okay, vitamin B6 pyridoxine. So alcoholism, yep, as a replacement, because again, water-soluble vitamins washed away into the urine, and the B vitamins are all water-soluble, including vitamin B12, but vitamin B12 is the only water-soluble vitamin that can be stored in the body, and it's stored in the liver and you have stores of many, many months, even into the years you have stores of B12. The other reason for using vitamin B6 as a medication is patients that are on isoniazid can get a peripheral neuropathy from B6 deficiency. So if someone's on isoniazid for tuberculosis and they come in with bilateral leg numbness or tingling in their legs or arms, they'll be prescribed pyridoxine, vitamin B6, to reverse those effects of the isoniazid. Okay. The actions, of course, it's also involved in metabolism of the body. The above two are just, certain treatments where we, alcoholism and isoniazid-induced peripheral neuropathy, where we actually prescribe vitamin B6. And below are the food sources. It's interesting, it's in yeast, wheat, corn, and organ meats. Okay, vitamin B9, which is folic acid. So the conditions where we use vitamin B9. So definitely, well, in alcoholics for sure, because they're so deficient of many vitamins. Pregnancy, so in your prenatal vitamins, they typically have decent amounts of folic acid to prevent neural tube defects early on in pregnancy. And also folate, along with vitamin B12, goes to the bone marrow to help maturation and full production of red blood cells. And without folate or B12, vitamin B12, you'll get immature red blood cells that are large. And when we look at them under the microscope, we can see that they're large red blood cells called macrocytic. So one of the causes of a macrocytic anemia is B12 or folate deficiency. So if we do a blood test and we see someone's anemic, say their hemoglobin is 7, and we look at the cells and we realize, okay, those are large red blood cells. Well, so we know they're anemic, and now we know that the red blood cells are large. And 2 causes of anemia with large red blood cells is folate deficiency or B12 deficiency. There's a few others, but these 2 are definitely checked because they're easy fixes. Okay. The food sources we've already gone over, so I'll save a bit of time here. Remember, this is a water-soluble vitamin, not stored anywhere. Very important in early pregnancy and very important in producing red blood cells properly. Okay, so vitamin B12. So vitamin B12 can come in tablets. It can come as an injection, which is often given, and it can come as a nasal spray as well. Okay, so the vitamin B12 tablets, in order for them to be absorbed, you really have to have a functioning stomach to release the intrinsic factor that binds vitamin B12, and you have to have an intact small intestine with little disease there, such as Crohn's disease or other malabsorption diseases, because even if you have B12 in the small intestine with intrinsic factor, if it can't be absorbed, you still have the same issue, right? So that's where we turned to. So you can give, you can give as much oral vitamin B12 as you want. If you're missing intrinsic factor, or if you have a malabsorption syndrome, you are unable to absorb it. So that's where we turned to injectable vitamin B12. And this was typically given, or is typically given, once a month. So often in family medicine clinics, there's patients that come in for their monthly B12 shots, right? And that's just to maintain their liver stores of B12 so they don't become anemic. And the reason it's typically older people is because older people are the ones who get atrophic gastritis. So atrophic, again, meaning thinning and decreased functioning, and gastritis, inflammation of the stomach. So, which causes pernicious anemia because you don't secrete intrinsic factor. Okay, so malabsorption syndromes under indications here, such as Crohn's disease or celiac disease, can cause a low B12 level. So they would be candidates for a vitamin B12 injection monthly. Deficiency in diet, so a vegan or a vegetarian, well, they can take oral B12 they don't have an absorption problem. They have a dietary intake problem. So they can just easily take oral B12. Someone who has B12 deficiency causing macrocytic anemia, well, the route of administration depends on what the problem is. If it's the problem with the stomach, not producing intrinsic factor, or if it's with the small intestine not absorbing, we'll just give it as an injection and maintain their vitamin B12 levels that way. If it's purely dietary, like an older person that just isn't having a good diet, we can try oral B12. That doesn't always work because often it's from lack of intrinsic factor called pernicious anemia. And there's the last one. So chronic gastritis causing pernicious anemia, reduced intrinsic factor. Okay. So actions, red blood cell maturation, and also maintenance of the myelin sheath. Where do you find B12? So in lean meats, definitely in liver and kidneys. So there's your options. You can also find so many animal products basically will have B12. So fish, poultry, eggs, milk, and fortified cereals will have B12 added to them. Okay, so let's go through that again. So definitely liver, because that's what stores vitamin B12. Fortified cereals, fish will have B12. Meats will have B12. Salmon will have high levels of B12. Milks and yogurts, and eggs and chicken will have B12. Okay? Okay, so on to vitamin C here, or ascorbic acid. Again, water-soluble vitamin. This is really a vitamin required for maintenance of collagen and other tissues. I mean, collagen is the main protein in soft tissues, right? It's what gives different parts of your musculoskeletal system strength. So as well, vitamin C is involved in wound healing. That'll be part of soft tissue maintenance. It'll be part of maintaining your oral cavity, your dentition, so how your teeth are being held in at your gums. So people with scurvy, for example, will start to lose teeth because the gums can't hold them in their socket. They'll start to get bruising and bleeding at the soft tissue. They'll get wounds and ulcers that can't heal because of lack of healing ability. Okay. Very easy to maintain vitamin C levels. So easy that the body doesn't even store any, right? It just flushes out extra vitamin C. So people taking large amounts of vitamin C to fight the common cold, they're not able to store vitamin C. It's just going to become expensive urine, because that's where vitamin C goes if you've taken more than the body's requirements. Okay, this next slide on minerals, recommended daily allowances and functions. So this is interesting. So calcium, 1,000 to 2,000 milligrams per day. Calcium tablets usually come in 500 milligrams. So you're looking at 2 to 4 tablets per day for calcium. So it's responsible for forming the your bony skeleton, basically. It also regulates nerve conduction and muscle contraction. So that's where calcium has its functions, right? So contractility of muscles, including the heart, and nerve conduction, plus the huge storage of calcium you have in your body is in your bony matrix. Chloride, that's the main. You don't hear much about chloride. That's the main anion in your bloodstream, and also part of gastric acid secretion in the form of hydrochloric acid, right? HCl. Magnesium. Magnesium's heavily involved in many enzyme processes, and also important in nerve and muscle contraction. Where do we use magnesium as a drug? We could use magnesium in, say, a particular form of ventricular tachycardia, which is a dangerous arrhythmia of the heart, called torsade de pointes. We use intravenous magnesium. We use intravenous magnesium to try and slow down or stop preterm labor. And we use intravenous magnesium to try and prevent a seizure in preeclampsia, otherwise it would be called eclampsia, or to treat seizures in a pregnant woman that has eclampsia. So either high-risk preeclampsia to prevent seizures, or to treat seizures in eclampsia. Okay. Phosphorus, that's the other part of the bony matrix, also heavily involved in well, it's part of your energy. It's your main currency of the body for energy, right? Adenosine triphosphate, ATP, and also it's part of nucleic acids in your DNA and RNA. So calcium phosphate is the main storage, right, in the bony matrix. Potassium, that's your main intracellular cation that's needed for of course action potentials, so nerve conduction and muscle contraction. Heavily involved in acid-base balance, right? So if your blood becomes very acidotic, your cells, your millions and millions of cells can trade an acid. They'll take an acid and put out a potassium to try and hide some of the acid in the cell. So it's involved in acid-base balance. Sodium, that's your main extracellular cation. Again, heavily involved in nerve conduction, action potentials, okay, and muscle contraction, and also of course, involved in electrolyte and acid-base balance. Sulfur, don't think you'll hear too much about this. Yeah, component of proteins, B vitamins. We won't go into that too much. Okay, I won't continue down this list here. These microminerals. I think just to take a look at them and see that you actually do need all these in small amounts. You typically find them in your foods. I mean, I think they're interesting to look to see exactly, which part which part of the body they're involved in. But anyways, I don't think you need to memorize this slide. I think you probably already know the common ones, iron, fluoride, and on the earlier slide, I think there were some more common ones there. Okay, let's. Okay, so we're just going to briefly talk about iron supplements and potassium supplements, and then move on to TPN after that. Okay, so let's just talk about iron a bit, because it's not an uncommon medication or supplement to give patients with anemia. So iron is often given orally, and it comes in three forms: ferrous sulfate, ferrous gluconate, and ferrous fumarate. Okay. The IV form and IM form is iron dextran. The IM form is not given that often. It stains the tissue. So you can imagine you're injecting iron into muscle, but it stains the tissue. So, but it is often given IV as iron dextran, and that's for someone who's unable to take oral potassium, oral iron, and there's many reasons for that. It's hard on the gastrointestinal system. You may have a disease of the gastrointestinal system that makes it difficult to absorb iron in the first place. Or you really want to get the iron stores up fast with intravenous iron. Okay. So let's move on to some indications here. So really anemia, so iron deficiency anemia would be the most common reason for using oral iron or intravenous iron. So you're losing iron somehow. So how can you be iron deficient? Well, the first way is you just have a terrible diet. And you are not getting enough iron in your diet. Okay, that's possible, especially in, not that they have a terrible diet, but people with that are vegetarians or vegans, it can even be more difficult to get proper iron stores in, or maintain proper iron stores to produce red blood cells. The more common reason is that you're losing iron, and some iron loss is normal. For example, in women, every month they lose iron when they're premenopausal in the form of having menstruation, right? So women with heavy periods can lose large amounts of red blood cells, which is iron, and they can become iron deficient, especially if they're not maintaining it in their diet. Okay. Patients that have slow, gradual blood loss in their gastrointestinal tract, such as from gastritis or a peptic ulcer or a colon cancer, something that's causing them just to leak red blood cells over time, chronically, they will become iron deficient. And we will notice that on blood tests, where we will see that not only are they anemic, but iron deficiency causes a microcytic anemia, tiny little red blood cells, because they didn't have enough iron to produce normal size red blood cells. So the bone marrow made these tiny little red blood cells called microcytic anemia. Okay. And the other blood test that we use is ferritin. So ferritin is a very sensitive blood test to show iron stores. So a normal ferritin is very reassuring to show that you have normal iron stores. So patients that are iron deficient, they've depleted their iron stores, they have a low ferritin. Okay, so that would be the most common reason for receiving oral iron or intravenous iron, is iron deficiency anemia. Now we can give people with chronic kidney disease iron, but often their issue is not iron, it's more erythropoietin. Or lack of erythropoietin production. So often they need injections of erythropoietin to maintain red blood cell production. Okay. The other indication is someone who has iron deficiency, whether because they have heavy periods or because they're being investigated for very gradual blood loss from the gastrointestinal tract. Say they have colon cancer and they don't know it yet, but they're being investigated for it. But we've detected iron deficiency anemia. We will give them iron to maintain their hemoglobin levels and also investigate them at the same time. Okay. A patient that's unable to receive blood transfusions for religious reasons, well, they can't take blood products, so we're going to try and find out the reason why they're iron deficient, and at the same time supply them with iron supplements to maintain proper iron stores. Okay. So actions provides iron for RBC development and production. True. Adverse effects when taken orally, definitely nausea, very constipating, turns your stools black. Liquid iron can stain your teeth, and intramuscular iron can stain at the injection site. Okay, so most of the time, some older people especially just can't take the oral iron because of nausea and constipation. Remember the 3 causes of black stools. Melena, that's blood. Iron, that's iron. And Pepto-Bismol, because it has bismuth in it, it turns your stools black. Okay, that's the 3 causes of black stools. So depending on what form of iron you take, it can stain, right? Teeth, that's liquid iron. Skin, that's injectable IM iron. So sometimes we just revert to IV iron to get the iron in when they're having difficulty taking it orally. Contraindications, well, hemochromatosis is an iron overload disease, so you wouldn't give someone hemochromatosis extra iron. Unable to tolerate it due to GI upset may require IV iron. We spoke about that. Take iron on an empty stomach 1 hour prior to meals, and 2 to 3 hours between other medications. Yeah, so you try and keep iron away from other medications. Remember, your stomach takes about 2 hours on average to empty, so 2 to 3 hours between other medications is a good idea. Stools change color to black for sure, and maintaining fluid intake, and also maybe putting them on a high fiber diet to avoid constipation. Those are the food sources that contain iron below there. So remember that sometimes it's better to take iron on an empty stomach, but sometimes you just can't, and you have to add a small meal because of the GI side effects of nausea and stomach upset. Okay, so sometimes you don't have a choice. It'll cause less absorption of the iron, but sometimes you just don't have a choice. You do try to avoid milk, antacids, and calcium, because that will reduce the absorption of the iron. And vitamin C increases iron absorption. Okay, so ingesting vitamin C, whether it's in orange juice or as a tablet, will increase iron absorption. And remember, vegans, vegetarians are probably the most common group that cannot get enough iron in their diet. Okay, so they don't have necessarily a disease state, but they're unable to get enough iron, because iron is often found in meat, right? So liver, organ meats, red meats, very high in iron. But also it's in spinach, legumes, cereals, beans, and lentils. So vegetarians can still maintain iron levels by consuming those foods. Okay. So iron deficiency anemia there's two issues. There's, okay, I need to replenish the iron so that they can build up their red blood cells and not be anemic anymore. But the other issue is finding out, why are they iron deficiency? And why do they have iron deficiency? There's a reason for it. So it could be, as mentioned, very heavy periods. It could be an awful diet. It could be bleeding in the stomach or bleeding in the colon. But there's a reason why someone becomes iron deficient. Okay, so the next slide's on potassium chloride, which is a pretty common electrolyte medication that we administer. People often come in with hypokalemia from a variety of sources or causes. So prolonged nausea and vomiting, profuse diarrhea, diuretics, so hydrochlorothiazide, furosemide. People often become hypokalemic, either because they're not keeping up with potassium intake, or the diuretic was increased or adjusted and they've become hypokalemic due to potassium losses. And by far the most important electrolyte abnormalities we get concerned about are potassium abnormalities, because hyperkalemia is very concerning for the heart, heart conduction, and can be deadly. And hypokalemia can cause a lot of cardiac conduction abnormalities. Okay, so because potassium is so involved in nerve impulses and conduction and electrical stability of nerves, when it becomes hypo or hyper, it's concerning. Acid-base balance. Remember that potassium can shift in and out of cells and trade off with hydrogen. So potassium is part of the acid-base balance. So if you have too much hydrogen, meaning you're acidotic, the H plus can go intracellular and potassium can come out of the cell in order to hide that excessive acid that's in the blood, because a low pH is extremely dangerous to the body and to all the functions of the body. Okay, so oral potassium, very hard on the gut, nausea, vomiting, diarrhea, awful tasting. It's often mixed with a juice just to help with the taste of the potassium. So abdominal discomfort definitely as well, along with the nausea, vomiting, and diarrhea. Hyperkalemia, if too much is given, or if we give potassium in the setting of someone who has renal failure and they can't excrete potassium, they can become hyperkalemic. So we have to be careful with that. And also the other thing that's very common with potassium is it causes a phlebitis in the peripheral IV. So if we give potassium in too large of a concentration, or if we give it too fast, it can cause phlebitis of the vein, inflammation of the vein that's going into. Okay, so contraindications, well, severe kidney disease, because we're likely going to make you hyperkalemic since you're not getting rid of potassium. Definitely someone who's hyperkalemic already, we would never give potassium. Major trauma and burns are typically releasing large amounts of potassium from damaged cells. So intracellular potassium is being released. So we would be very careful adding potassium to someone who's had a major trauma or significant burns. In terms of levels, remember the potassium likes to be between 3.5 and 5. In a peripheral IV, we usually give up to 10 milliequivalents per hour. In a central IV, so a central line, much bigger vein, we can give 20 milliequivalents per hour. We never, ever, ever push potassium. Okay, in actual fact, potassium is now mixed in IV bags when it comes to the hospital. So the bag might say 20 milliequivalents per liter or 40 milliequivalents per liter, and it's in big bold red. Actually, we actually can't. We don't have potassium to put into IV bags any longer. That's changed to reduce errors of putting too much potassium into the IV bags. Okay, so we never bolus or push straight potassium. It can be deadly. And in terms of dietary sources, many fruits, vegetables, vegetables such as apricots, prunes will have potassium, nuts. Bananas have some potassium, not as high as you might think. Potatoes, orange juice has a lot of potassium, or oranges. Beets have a lot of potassium. Okay, and remember, so we can give potassium orally, in a pill form, or in a liquid form, or we can give it intravenously. And it really just depends on the circumstances, right? So if someone's not vomiting and they just have low potassium, we might give it orally as a pill, or as an elixir, as a liquid, as long as we just mix it with something to help with the taste. And then IV, if they already have an IV and we want to maintain their potassium while they receive intravenous fluids, we'll choose an IV solution that has potassium already in it. So it might be normal saline with 20 milliequivalents of potassium, or normal saline with 40 milliequivalents per liter of potassium. So it really just depends on the circumstances. Okay, so let's talk about magnesium a bit. Let's look at the indications first. So hypomagnesemia. So we don't always check patients for magnesium levels, but often, so with hypokalemia, so low potassium, you are almost always low on magnesium. So potassium and magnesium really go together. As you are drained of potassium, say with a diuretic, you are also drained of magnesium. So often we'll add it to a patient's intravenous fluids along with potassium. Okay, so they'll get IV potassium, say, for maintenance of their potassium, and also IV magnesium. It's a great laxative. So milk of magnesia is a perfect example, right? Someone's constipated, you want to treat them with some kind of a laxative, milk of magnesia, and it's the magnesium part, okay? So the next one is stopping preterm labor. We use IV magnesium to try and reduce contractions and stabilize the myometrium, which is the uterine muscle, to stop preterm labor. We use it as an anti-seizure medication if someone has eclampsia in pregnancy, or if they're at high risk of getting a seizure because they have severe preeclampsia. We can use IV magnesium. So remember, the difference between preeclampsia and eclampsia is just seizures. You haven't had a seizure with preeclampsia. With eclampsia, you have everything that preeclampsia has, plus you've had a seizure. Okay? And the last one to remember here is, I don't see it listed, but a form of ventricular tachycardia of the heart. So a dangerously fast rhythm called torsade de pointe. Okay, that's a French term, torsade de pointe, and it's the other term for it is polymorphic ventricular tachycardia. Polymorphic just means different forms of the QRS. So if you remember ventricular tachycardia, and it's called torsade de pointe, I think you're doing fine. And it's usually caused by either drugs or a congenital condition that widens your QT interval on the ECG and puts you into torsade de pointe, ventricular tachycardia. Okay? So the actions we won't go too much into here. Adverse effects. Muscle weakness, it can. So diarrhea, of course, because it's a laxative. AV conduction suppression. So in toxic amounts. Remember it tries to control ventricular tachycardia. If you have torsade de pointe, so it has cardiac effects. So contraindications: renal failure for sure, because the kidneys would have trouble clearing the magnesium, just like they would have trouble clearing the potassium. If someone has a heart block, an AV nodal heart block, you wouldn't add potassium. That could aggravate it. And of course, if someone has nausea, vomiting, diarrhea, and abdominal pain, well, you're probably going to make it worse with magnesium because it's hard on the gut. Okay. What kind of foods will you see it in? Well, they're listed there. So cereals, nuts, green leafy vegetables, bananas. So the main way you will become low on magnesium is because you've become low on potassium. And the main way of doing that is typically with taking diuretics. Okay, so let's spend a bit of time talking about enteral and parenteral nutrition. So enteral nutrition is using the gastrointestinal tract for feeding. So whether it's with an NG tube, a nasogastric tube, or a gastric tube, or a jejunostomy tube, both of those go through the abdominal wall and into the stomach or into the jejunum. As long as you're using the gastrointestinal tract for digestion and absorption, that would be called enteral feeding. Okay, and enteral feeding is used for many reasons. You may have difficulty swallowing. Maybe you had a stroke. Maybe you have an esophageal blockage and difficulty getting the food down. Maybe you're so sick that you're in a coma, or you've had some major burn and you're unable to eat right now. So you still need the nutrition and the calories to heal your body. So that's enteral feeding, and that's usually preferred over parenteral nutrition, which is intravenous nutrition. And that's not just a bag of normal saline or D5W or lactated ringers. That is all the nutrition that you need in an IV bag. But definitely enteral feeding is preferred, since it's using the natural way of getting food into the body, which is the gastrointestinal tract. Okay, so we'll talk a bit about both enteral and parenteral nutrition. Okay, so let's talk about enteral feeding a bit. So before we look at some of the things on this list, let's just think about how are we going to feed someone that can't, say, chew or swallow, but we want to use the gastrointestinal tract since it's still functional. So what are the different routes we can use? Well, we can put a nasogastric tube in, so it's a tube that goes through the nose, very uncomfortable, down the esophagus into the stomach. We can go a bit further and use a nasoduodenal tube, or even a bit further, a nasojejunal tube. So why does it matter? Well, the further you go down, the less chance there is of refluxing and aspirating food back up, potentially into the lungs, right? So there's different options of where you can put the tube. The other way is to go through the abdominal wall. So you can have a gastrostomy, which is a tube through the abdominal wall right into the stomach. Or you can have a jejunostomy, which is a tube through the abdominal wall. And often it's called a gastrojejunostomy, meaning it's gone through the stomach first, and then the line's been moved down, or the tube's been moved down to the jejunum. And that also helps prevent reflux of food and aspiration into the lungs. So those are usually longer term tubes when we're putting in a gastrostomy or a gastrojejunostomy. Okay, so and the whole idea is, let's use the gastrointestinal system since there's nothing significantly wrong with it. Otherwise, it'll gradually shut down, right? So the bile likes to be used, the pancreas likes to be used, the digestive juices, absorption of the by the small bowel. It's all very important to keep it using. Otherwise, things will gradually stop functioning, and we'll run into problems later when we want to restart regular eating. Okay, so always preferred over TPN, total parenteral nutrition, which is IV. Okay, so undernourished patients may be caused by drugs or treatment. So advanced age, for sure, if someone's sick and it's looking like they may need 10 to 14 days or even longer of nutrition, we would put in an NG tube or an NJ tube, a nasojejunal or a nasogastric tube, to provide them with food. Because if they're not able to eat, they don't have a lot of reserve, older people, okay? What else can impact eating that may require a tube? So oral thrush, candidiasis of the mouth, so antibiotics can make it difficult to eat. Anticoagulants can make it difficult to eat with bleeding gums. Chemotherapy agents, antineoplastic. You can get terrible oral ulcers, and of course nausea and vomiting, right? Captopril can give you, so that's an ACE inhibitor, that can give you a bit of a bad taste in your mouth. Probably not going to get an NG tube for that. Maybe just stop the drug. Coma, yeah, definitely. Someone in a coma that's unable to maintain nutrition would be a candidate for enteral feeds. Eating disorders, someone who cannot maintain their weight and they're gradually losing weight and getting sicker and sicker, may require an NG tube. Inflammatory bowel diseases can sometimes require NG tubes. You can have Crohn's disease in your mouth, you can have it in your esophagus, you can have it all over. And sometimes we'll provide them with enteral feeds that are easily digestible. Now, other times with severe Crohn's disease, it doesn't matter what you put into the gastrointestinal tract, it's not being absorbed. So someone with severe Crohn's disease may need TPN because of the malabsorption from Crohn's disease. Major burns and trauma, someone who's very sick with that may need enteral feeding. They're so sick they're unable to eat or chew or swallow, and they may end up with an NG tube for enteral feeds until they get better. Because these injuries, whether it's a burn or trauma, uses tremendous amounts of energy every day, of calories to heal the wounds, right? Neuromuscular disorders, central nervous system disorders such as a stroke, where they can't swallow, they recurrently aspirate into their lungs, they may need an NG tube. Premature babies that are unable to feed or nurse often get NG feeds. Radiation, so if you have radiation, say for a lung cancer, you get terrible inflammation, say, of your mouth or your esophagus, depending on where the radiation hit. They may need NG tubes until they improve. Okay. Severe infections from HIV. So patients with HIV can get esophageal candidiasis, meaning, so thrush is in your mouth, and HIV patients often presented as adults with thrush, but they'd have the candidiasis all the way down the esophagus. And sometimes they needed NG feeds because they couldn't swallow because it was so painful. So deciding on the route to take to access the gastrointestinal system partly depends on how long the enteral feeds will be required for. So short-term feedings, maybe for days to a week, 10 days, typically will be with a nasogastric tube. Remember, nasogastric tubes are extremely uncomfortable. They're tugging on the end of your nose. They go down the back of your throat. People really don't like them. And they're uncomfortable to put in as well. And it also depends on the condition, right? So different conditions, say you have esophageal cancer. Well, there's no sense in putting an NG tube down. It probably won't get past the esophageal tumor or obstruction. So it just depends on the condition. But in general, short-term feeding would be with a nasogastric tube. Longer-term feeds for weeks or months or longer would go through the abdominal wall into the stomach, and that would be called a percutaneous endoscopic gastrostomy tube. Okay, and remember, when it goes through the stomach, you can leave it in the stomach, or you can put it further down into the duodenum or into the jejunum. Okay, so I'm not going to spend too much time on this slide. This is drug administration guidelines with enteral feeds. So, I mean, if a patient is able to take medications by mouth, definitely the oral route is preferred. Alternate routes of administration: IV, IM, rectal, sublingual, or transdermal through the skin. It can always be considered for medications that cannot be crushed or don't come in a liquid form. Or some medications just clog up the tube, and that's one of the complications of having an enteral tube, right? It gets repeatedly clogged. You don't usually need sterile technique since it's the gastrointestinal tract, right? So, I mean, clean technique, sure. Sterile technique, no. People don't need to be sterile when they're eating. So now, if someone's severely immunocompromised, that's different. We're very careful with sterile technique in someone who's immunocompromised, so that we can avoid giving them an infection. Always checking compatibility of medications with the tube feeding before giving it, and making sure that you can crush the medication. Okay, so let's go on to the next slide. So here's the typical guideline for giving medication through enteral feeding tubes. So flushing the tube with 30 mL of water before and after the medication. All medications are always given separately, right? we don't make a slurry of like 5 or 6 medications and then push it in. They're given individually. Okay, and they're often mixed just to dilute them a bit so that they're not too thick. Between the medications, 5 to 10 milliliters of water to flush the line again. Most drugs that come in a liquid or an elixir they're viscous, they're thick. So often they need diluting, some dilution with water so that they can easily go through the tube. And that also avoids irritating the stomach when you've diluted the medication, so that it doesn't land on one part of the stomach and irritate the stomach. Medications aren't added directly to the feeding formula, never, right? So the formula is actually turned off when medications are being administered. So most medications require their enteral feeding to be stopped, usually for 15 to 30 minutes, and then before and after, and then you can restart with the enteral feeds. So this slide, we won't go into too much detail. I mean, it's really just a list of different medications, and with physical incompatibility is increased osmolality and decreased drug effects. That's just for your own information of interactions with enteral formulas. I don't think anything needs memorizing here. Okay, so let's just talk about enteral formulations first. So an enteral feeding are different formulations that we use to get nutrition into someone who is sick. So it's either going to be down an NG tube or into the stomach through a gastrostomy tube, or into the jejunum through a jejunostomy tube. So, and we've spoken about the fact that NG tubes are typically for short-term duration, gastrostomy and jejunostomy tubes are for longer-term duration feeds. And the formulations are different too, right? Some people that have gastrointestinal disease are unable to break down complex carbohydrates and fats and proteins. So say someone with severe pancreatitis, we don't want to give them full meals that haven't been partially digested before putting them into the tube. So a polymeric formula requires a fully functioning gastrointestinal tract. It's basically a full liquid meal replacement. And it would have all the vitamins and minerals along with the carbohydrates and fats and proteins. An elemental formula would be where the proteins, the fats, and the carbohydrates have been significantly broken down already in the formula into much smaller subunits that are much more easily digested and absorbed, okay, with far less digestive enzymes that are required by the patient's gastrointestinal tract. So they would be used more commonly in someone with a malabsorption syndrome, where there's no sense in putting down a polymeric formula for enteral feedings that cannot be broken down because the person's gastrointestinal tract isn't fully functional. Okay, and semi-elemental is somewhere in between, right? So they still have small peptides, small carbohydrates, and small fats, but a bit more than monomeric, which is the elemental one, but definitely not full proteins, carbohydrates, and fats. So they're more easily absorbed. They don't need as many enzymatic breakdown in the gastrointestinal tract. So they can be infused directly into the intestines. And it's also for people with malabsorption syndromes or partial bowel obstructions, inflammatory bowel diseases where digestion is a real problem. So these can be minimally digested and then easily absorbed. Okay? So I would think of it as a spectrum from monomeric, uh, oligomeric, which is the semi-elemental, and then polymeric, which is basically full proteins, full fats, and full carbohydrate sizes. Modular formulas are more specific, so they're more specific to certain diseases, and specific nutrients are put in. So they're not complete formulas, right? So they may have only one macronutrient, such as they may just have carbohydrates or protein or fat. Okay, so they don't meet 100% of the patient's nutritional needs. So they would be used in specific diseases where you want to avoid, say, large amounts of protein or large amounts of carbohydrate. So they're more tailored to the disease and the patient, but much more difficult to make, right? So they're say you want a protein-free modular formula or a fat-free modular formula. Okay, so refeeding syndrome. So if someone starts to eat after a period of days to weeks of having not eaten. So you can see here under this list, anorexia nervosa, someone who's eaten very little. Kwashiorkor, which is severe malnutrition, not often seen in North America. Chronic alcohol abuse, probably haven't eaten properly for many months. Prolonged fasting, prolonged IV hydration. So it's where the gastrointestinal tract hasn't been used, but also what's happened in the bloodstream. So during fasting from any of these conditions, the body switches from using carbohydrates, sugars, and starts breaking down fats, okay? And it also starts to break down some of its protein to amino acids as its main form of energy. Now, in order to do that, the body needs to use potassium, magnesium, and phosphorus for all of these processes to occur. Then, upon refeeding or reintroducing food, what will happen is that, well, first of all, insulin will increase because it's detecting suddenly some sugar in the bloodstream, and that will result in glycogen storage. That will result in some fat production because the glucose in the bloodstream that has stimulated insulin will say, okay, let's produce some fats for storage for a later time. Let's make some glycogen. Let's start making protein synthesis since we're now getting some energy. And all of these processes, since reintroducing the food, needs phosphate, magnesium, and potassium, which are already low because of the starvation process. So those electrolytes can become critically low. So these significant electrolyte fluctuations can make someone very sick. They can lead to dehydration, electrolyte imbalances, hyperglycemia, and finally confusion, seizures, and coma. And really, this is all from major electrolyte shifts that we've just spoken about. Phosphorus, magnesium, potassium, and huge fluid shifts, right? So that can put a real stress on the heart. It can affect the neurological system, as you can see here, by confusion, seizures, and coma. So refeeding syndrome can be fatal if not dealt with quickly. So really, I mean, the prevention of this is, check all these electrolytes prior to refeeding, since these levels can be low even prior to introducing food, which is going to make it go even lower. Okay, so you can run into all kinds of organ failure because of these major changes in potassium, phosphate, and magnesium. Okay, so remember, it's a neurological condition. You can go into congestive heart failure. You can run into dehydration, all kinds of issues. So I remember the concept of what refeeding does. It drains you more of some very important electrolytes. Okay, phosphate, potassium, and magnesium. And what causes it? Well, anything where there's been starvation, right? So anywhere, or alcohol abuse, because that's a form of starvation, because you haven't been eating food. Okay. Okay, so let's talk about total parenteral nutrition. So parenteral is intravenous, and again, we're not just talking about D5W or normal saline or lactated ringers. We're talking about a complete intravenous nutrition supplement for people that are unable to eat, or have such severe gastrointestinal disease that they're unable to digest the foods at all. So an example would be someone who's had a severe stroke, and enteral nutrition has been attempted. For many reasons, it's not working, whether they're aspirating the food back into their lungs and getting recurrent pneumonias, or they have severe diarrhea from the enteral nutrition. Many factors. Sometimes the enteral nutrition just doesn't work, but it's often the first choice. Or they have a gastrointestinal disease such as severe pancreatitis, or end-stage liver disease, where they just can't break down the foods in the enteral nutrition. And finally, a condition such as Crohn's disease, where many sections of the small bowel can be surgically removed, and they end up with a short gut syndrome, or a short bowel syndrome, where they just can't absorb. They don't have enough small bowel to absorb, to digest and absorb the enteral nutrition, and they end up on TPN. Okay, so adhesions. Adhesions just refer to someone who's had repeated surgeries, and now they have a lot of scarring of the bowel. They get recurrent bowel obstructions, and they're just not able to eat or tolerate enteral feeds. Sometimes patients with severe wasting diseases, such as AIDS, where they don't want to eat. They're not hungry, they're sick, they're losing weight, and just to try and put some weight back onto them, and to provide them with the vitamins and minerals that are required, plus of course carbohydrates, fats, and proteins. TPN is offered. Crohn's disease, again, very common, because often you have severe malabsorption with Crohn's disease, and they can end up on TPN. In fact, I would say this was one of the most common reason you could have a whole ward of patients with Crohn's disease, and they were, often walking around with TPN dripping in because they had lost so much of their bowel, of their small intestine, that they couldn't absorb the food or enteral feeds, and they'd end up on long-term TPN. Patients that have fistulas, so connections between different parts of the bowel. So again, this is probably Crohn's disease again, which is the most common cause of fistulas in the bowel, where they have such scarring. Fistula is basically a connection from one tube to another. That's a fistula, and Crohn's can classically do this. So they have malabsorption, chronic abdominal pain. They can't tolerate enteral feeds. They end up on TPN. Hyperemesis gravidarum, a woman who has severe vomiting and nausea, often in the first trimester, but sometimes it can go into later trimesters as well. And they become severely dehydrated, electrolyte depleted. They're losing weight. The fetus isn't gaining any weight. Will end up on TPN to maintain nutritional status, right? Pancreatitis. Someone with pancreatitis isn't releasing peptidases, so proteases or lipases to break down the food. So they have a malabsorption syndrome because of that. And they may end up on TPN because even if you gave them enteral nutrition, they may not be able to absorb it. Pediatric patients with congenital anomalies or prolonged diarrhea. So pediatric patients that have abdominal, some kind of digestive problems, gastrointestinal diseases, severe diarrhea, they can end up on TPN to maintain their nutrition. So remember, it doesn't take long to actually lose a lot of weight if your gastrointestinal system isn't working well, right? Especially in an older person. It doesn't take, we're talking about days to weeks where they're losing weight, they're losing muscle mass, they're losing the fat. And so sometimes just being old and sick, you might end up on TPN or enteral feeds at a minimum. Post-operative ileus, well, so that's where the bowel just isn't functioning after a surgery. It hasn't woken back up. It's usually after a gastrointestinal GI type surgery. If the bowel is touched or operated on, it kind of goes into a shock state and the peristalsis stops. So people can't eat yet, they're nauseated, they're vomiting. And if it's prolonged, they may require a course of TPN to maintain nutrition. And of course, radiation induced, if you had a lot of radiation to your gastrointestinal system or your abdomen, that can cause a lot of inflammation in the gut, malabsorption, and they may require TPN to maintain nutrition. So lots of different possibilities to end up on TPN for a period of time or long-term in certain diseases. Okay, so this next slide is just showing you some potential complications of TPN. And these are more mechanical type complications. So it's not really related to the feeding part or say an IV tube infection. But let's look at some of these. So a pneumothorax, well, when you're putting in a line, an IV line for TPN, whether it's a PICC line, a peripherally inserted central catheter, or a central line that would go into, say, the subclavian vein. There's more chance when you're trying to get a central line, such as a subclavian line, that you may, because the lung is very close, you may puncture the lung with the needle, right? And cause a pneumothorax, which is a collapse of the lung. So that's always a risk. And if your lung collapses, it's actually peeling away from the chest wall. What symptoms will you get with that? Well, you're going to get pleuritic chest pain. So when you're taking breaths, it's going to hurt. You'll have reduced breath sounds on that side, and you'll likely be short of breath in general because one of your lungs has collapsed. Hemothorax, you might hit a little blood vessel that's within the thoracic cavity, and it starts to bleed. And again, reduced breath sounds on that side, chest pain on that side because it's filling with blood, shortness of breath because as that side of the chest fills with blood, you'll get short of breath. Hypotension, if it's a bad enough bleed, well, you're losing blood into your thoracic cavity. You're going to get hypotensive. You're going to get tachycardic. You're going to get dizzy, weak, pale. Okay. Hydrothorax. This is where a catheter has been put into the vein, and TPN solution starts to run, and the vein is actually leaking. And what happens is that the TPN solution ends up in the chest, right? So it leaks into the chest. That's never good because you've infused basically food, which is TPN, and now it's kind of ended up in the thoracic cavity. Venous thrombus, for sure. So you can always form a little clot at the end of the tubing, which is just going to cause the tubing not to run properly. But you can also form a venous clot in the entire vein where the tube is. So say it's in the superior vena cava. The vein was inserted through a central line, and then the end of the tube was left in the superior vena cava. Well, if that gets blocked, anything that's trying to flow back to the heart from the upper part of the body, so the head, the arms, they all flow back through the superior vena cava. They're going to get swollen. So you can get something called superior vena cava syndrome, where it's the superior vena cava is blocked. You're starting to get swollen neck veins or distended neck veins, swollen arms, swollen face. And if you have a central line in for TPN, we definitely suspect there's a large vein that's clotted. Okay. Air embolism. So if there's a lot of air in the tubing or in the bag, that air is going to travel as a big bubble to the heart. Then it's going to be pumped out to the lungs. So that can cause that. And so instead of blood going to the lungs, you're now getting a bolus of air going to the lungs from the pulmonary artery. And that can cause shortness of breath, chest pain, cyanosis, because you're not oxygenating blood. You actually have air in the arterial circulation of the lungs, and coughing. So that's an air embolus. Okay. So these aren't all the complications of TPN. They're just some more mechanical complications. Okay, so this slide is now showing you other. So the first one were more mechanical complications such as a blood clot, a pneumothorax, a hemothorax. Those are all issues to do with the line either going through a vein and hitting the lung and causing a pneumothorax, or leaking TPN to the chest into the thoracic cavity, or clotting up an entire vein and causing like a thrombosis of the vein. These are more metabolic. So hyperglycemia, well, infusing fluid quickly, the TPN fluid, can lead to hyperglycemia, so high sugars in the bloodstream. Okay. And this would just lead to symptoms that anyone with high glucose levels would get, such as in diabetes. They'd have weakness, thirst. When we do a glucometer, their glucose levels would be elevated. And really, it's just a matter of slowing down the fluids or altering the solution of the fluids so they don't become hypoglycemic, hyperglycemic. Sorry, hypoglycemia is just the opposite. So if you're running if someone is having TPN run and it actually runs out, so the bag empties and you don't replace it, you can run into a couple of problems. So the first thing is that the body has insulin floating in it. It doesn't know that the bag's going to run out, so it's going to continue to move glucose into the cells. So if suddenly the TPN bag ends, but the insulin is still acting, you can become hypoglycemic. Okay, so that would be a reason to make sure that you have some kind of sugar solution that can be hung until the next TPN bag can be started, such as D10W, to make sure that they don't become hypoglycemic. Okay. And what happens when you become hypoglycemic? As your sugars start to descend, your body will activate the sympathetic nervous system to say, go and get some sugar into me. My brain cannot work without oxygen, and it can't work without glucose. So it's going to activate the sympathetic system. So you're going to become pale. You're going to become sweaty, tachycardic. You're going to have blurry vision. You'll have dilated pupils. You'll become tremulous. It's all the sympathetic system being activated, warning you that your sugar is dropping. Okay. Fluid overload. So, high IV rates from the TPN can give you a fluid overload. And not only the IV rate, but also the shift, because you're putting in a hyperosmolar solution. So you're going to get fluid shifts from the intracellular, which is not as osmotic, to try and dilute this solution that's going into the intravascular space. So you're going to get more fluid overload that way, right? So that will cause, that can potentially put someone into heart failure. So shortness of breath, distended neck veins, crepitations in your lungs from pulmonary edema, and of course weight gain. And lastly, infection. So you have a tube in your central line, in your central venous system. So that's always at risk for getting infected. So it could have been from a poor aseptic technique when the catheter was inserted, or contamination of the catheter when changing the tube, or when the TPN solution is being mixed up, or the dressing change. So you can get an infection at any point, right? Whether it was when the tube was inserted or later on during administration of TPN. So whenever you have a foreign body in the body, such as a tube or a catheter, you're always at risk for getting infection. And it could be a local infection around the tube site, or it could be bacteria that's now pouring into the bloodstream causing sepsis, right? So you can have fevers and chills, tachycardia. You might have abnormal drainage from the insertion site. Your white blood cell count will be elevated. If we draw blood cultures to see if we can grow any bacteria in the blood, they may be positive. Okay, so total parental nutrition considerations. So typically, the catheter ends up in a central line, right? So whether it's inserted peripherally and the tip of the catheter is in the central line, or a central line such as a subclavian line is used to access the central circulation. Administering a drug is usually through a non-dedicated line, since the TPN requires its own line for administration. So definitely flushing of lines prior to and after use is very important. And also determining if the drug and TPN have compatibility. TPN comes from the pharmacy, and certain medications that we'll get into can be added to TPN at the pharmacy level, but never after that. So medications are not added to TPN on the ward. It's only some that are added at the pharmacy level. Now, in terms of other medications that may be infused through a non-dedicated line, we turn off the infusion for 15 to 30 minutes to reduce any medication and formula interaction. And then, of course, there's flushing of the lines before and after use. So here's some medications that can be added. So ranitidine, which is an antacid, it's an H2 blocker to reduce acidity in the stomach. Regular insulin, Humulin R, which is the faster acting insulin, can also be added. And there would be endless amounts of medication incompatibilities, right? So I don't think we need to get into that. There's examples of some, but in general, just know the concept that we don't add medications to TPN once it's left the pharmacy. We can ask that something like ranitidine or regular insulin be added to the TPN while still at the pharmacy level. What drug would the nurse plan to administer if the TPN solution was not available in the unit when it was time to hang the next bag? So remember, you have circulating insulin because you've been infusing TPN that has carbohydrates in it. Suddenly the bag comes to an abrupt end. The insulin will continue to drive glucose into the cells, which will lead to hypoglycemia. So you should have a dextrose type solution such as D10W available until you can hang the next bag of TPN. Okay, so I mean, this is an interesting slide. I don't think we'll talk too much on it. Weight reduction strategies in obesity. There's so many options for weight reduction, including many different types of diets, altering the intake of different foods. There's surgeries to partially remove the stomach. There's stapling procedures on the stomach. There's all kinds of bypass, like gastrointestinal bypass surgeries that are available. And I think it's because by the way, there's exercise programs to try and lose weight. Although it is hard to lose weight just purely with exercise. It's more the caloric intake. And what you're eating. So if you're drinking large amounts of carbohydrates, sugar, well, the body's just going to turn that extra sugar that it doesn't need into fat storage, right? So just a well-maintained diet is really important. So we use BMI as an indicator of whether someone has a healthy weight for their size or their height, or if they're underweight or overweight or obese. Okay, and that's what this is showing here. So your BMI. So typically a BMI of 25 to 30 would be considered overweight, and over 30 would be considered obese. Okay, and between 18.5 and 24.9, that's considered a normal BMI. And remember, so BMI is your weight over your height squared. So usually it's in kilograms over meters squared to get your BMI. And why do we want to control or improve obesity across the country? Well, obesity is such a marker of other conditions. So it's almost like the starting point of many other diseases that can make you sick. So obesity, not only is it hard on the cardiovascular system because you're carrying much more weight. It's hard on the respiratory system because you're having to breathe more and faster. It's hard on the musculoskeletal system because the joints are carrying all this weight. So that can lead to more musculoskeletal injury, osteoarthritis, reduced mobility. It's hard on blood pressure. So people with obesity often have hypertension. They often have diabetes. Both of those can lead to cardiovascular disease. Both of those can lead to renal disease. Both of those put you at risk for atherosclerosis and strokes and heart attacks. So it's really a starting point for many other diseases. So losing weight and maintaining a proper body mass index is extremely important for long-term health. Okay, so let's talk about this medication called Orlistat. So this was a drug designed to treat obesity, right? Years ago, people would take appetite suppressant type drugs, but they were shown to have significant side effects, cardiac side effects. A lot of them were stimulants, so they just weren't safe. So a company came out with, well, let's try and see if we can reduce fat absorption with this drug called Orlistat. The brand name for it, Ali, or another one called Xenical, but I would just know it by Orlistat. And how does it work? Well, the main function is to prevent absorption of fats from the gastrointestinal tract. And how does it do that? Well, it also acts as a lipase inhibitor. So lipase comes from the pancreas. It stops lipase from breaking down the fats so they can't be absorbed. Okay. And the thought is by doing that, you reduce the caloric intake because you're not absorbing fats. Okay. So really, when you're taking this medication, you shouldn't be consuming large amounts of fats in your diet. Because if you ingest fats that are then blocked by being absorbed, you're going to get a lot of gastrointestinal side effects. So it's almost like, well, I'll take this drug and I definitely won't eat a lot of fats because I'll get tremendous gastrointestinal side effects as a punishment. So maybe just reducing fat intake could be another plan instead of having to take the drug. So what happens? So the adverse effects are really going to be explained by the fact that you've taken a medication, and the medication is going to, or the package is going to advise you not to consume significant amounts of fat, because when fats aren't absorbed because of this drug, well, you're going to get a lot of gas, okay, because fats aren't being absorbed in the small intestine. They're going to make it into the colon, where bacteria will break it down, and in the process will produce tremendous amounts of gas. Oily stool, well, the fats never got absorbed. So they made it into the colon, they made it out the back end, and you have greasy floating stools. And fecal urgency is when you have to go to the washroom, you have to go right now. You have fecal urgency. And that's also because of all the gas and the greasy stools that are being produced. So not a pleasant drug. Rarely used now because of this gastrointestinal side effects. So let's look at some of the contraindications. The first one, cholestasis due to inhibited gallbladder contractions. So cholestasis basically just means reduced flow of bile into the gastrointestinal tract. So if you have reduced bile, well, the bile is not mixing with the fat, so it's not emulsifying the fat. So there's going to be an issue with malabsorption already, and now you're adding orlistat, which is going to cause more malabsorption. So not a great combination. Malabsorption disorders, for sure. You're now making it much worse by adding orlistat that's going to cause malabsorption of fats. Anorexia and bulimia, well, they need calories, so you wouldn't want to block calories for being used. And definitely pregnancy, they need calories as well. So definitely this drug is not a pleasant drug to take, and it's rarely used now because statins can be used to reduce cholesterol levels, not that they control obesity, but this was a poorly tolerated drug. Many people had to stop taking it. The other thing that can happen is that because you're not absorbing fats, you're not absorbing fat-soluble vitamins, which are vitamin A, D, E, and K. Okay, and you have to take if you need additional vitamins, you have to take it 2 hours prior to the orlistat. So not only is the orlistat potentially making you vitamin deficient, but you may need replacement vitamins on top of that. Okay, so it can reduce any of your fat-soluble vitamins since they're not being absorbed. You have to decrease your fat intake, right? Otherwise, you'll get tremendous, as we just spoke about, gas, oily stools, fecal urgency. So not an overall fantastic drug and poorly tolerated. Okay, so this slide that has mint tea on it, I think. But it feels like a bit of a free slide, so I'm just going to go through some things that I've probably mentioned in a different way. Let's just talk about TPN again and some complications. So think about at the first part when they put the line in to get the central line in place. They can puncture the lung, cause a pneumothorax. They can hit a blood vessel, cause a hemothorax, bleeding into the thoracic cavity. Okay. Once the line's in place, it's at risk for getting infected. So the line can get infected with bacteria. The port that's being attached with the TPN can get infected, or the end of the IV tubing that's sitting in a large vein can become infected, and also the bloodstream can become infected, and that would be called bacteremia, which can then lead to sepsis, which is bacteria in the bloodstream causing fever, chills, hypotension, increased respiratory rate, confusion, okay, septic shock. So think of infection. Think of blood clots, whether they're blood clots that are just in the tube or blood clots in the large vein where the tube is sitting. If it's a blood clot just in the vein, in the tube, we can sometimes break that up by just putting a bit of a fibrinolytic in the IV tubing, such as alteplase, or another one called tenecteplase, just to try and break up that blood clot. If the blood clot is in a central vein, such as the superior vena cava, then you're going to get swelling of, or the patient's going to get swelling of their arms and their head, because the blood can't drain back down to the heart. And that's obviously much more serious. You can get what's called a fatty liver, because TPN has fat in it, in varying forms, and triglycerides, and they're processed by the liver. But it's not the same as what the gastrointestinal tract can do with processing of lipids. So it's not ideal, and you can develop a fatty liver from the fat content of TPN, and that can cause either a hepatitis, or worst case scenario, it can cause liver failure. And sometimes the TPN has to be changed because of developing a fatty liver. So typically it wouldn't be left until liver failure occurs. Cholecystitis can happen, so infected gallbladder. The gastrointestinal tract isn't really being used, so bile isn't moving very much. And since bile isn't moving and it's sitting more static in the gallbladder, it's more prone to forming gallstones. The gallstones can block the cystic duct and lead to cholecystitis, which is infection of the gallbladder. So that's more common with receiving TPN. Patients often describe feeling hungry often on TPN because their stomach isn't being filled. The signal isn't being sent to the brain. So that's another complication of TPN. You don't feel satiated. The next one is a condition called refeeding syndrome, where someone who hasn't eaten for weeks, say 7, 10 days, 14 days, and now we're introducing food through an IV line, can develop refeeding syndrome, which is characterized by low potassium in the serum, low phosphate, low magnesium. And often they can be hyperglycemic at the beginning, high glucose. So those minerals or elements that become extremely low are because the body is turning on its metabolism again with the introduction of TPN. So now it's using magnesium and phosphate and potassium. So you get very low levels in the bloodstream. Okay, and that can have cardiac effects, that can have neurological effects, they can go into respiratory failure. I think the most common cause of death is actually cardiac arrhythmias with that condition of refeeding syndrome. Okay, the next one I've already mentioned is hyperglycemia. So often when TPN is started, people can be hyperglycemic. But they can become hypoglycemic if the TPN abruptly stops, okay? Because there's insulin circulating now. And if the TPN were to run out, the insulin would continue to work, and it would make the sugar, the glucose, fall abruptly in the bloodstream, and they would be hypoglycemic. Okay, so let's finish there with a few reminders of TPN complications. I'll mention a couple of other things on the next slide, and then this module will be finished.